A 7-year-old patient arrives at the clinic with severe swelling around the eye. The eyelid is red, tender to the touch, and radiating heat. To the naked eye, this presents as a uniform problem. But beneath the skin, this exact set of symptoms masks two distinct bacterial infections. One outcome is a superficial skin infection that resolves quickly with routine outpatient antibiotics. The other is a severe ophthalmic emergency, capable of causing permanent blindness or death. Correct diagnosis and the resulting management plan rely on a precise understanding of orbital geography. Misdiagnosing the deeper, severe infection as a superficial one leaves the patient vulnerable. It gives the pathogen uninterrupted time to replicate and a direct anatomical pathway to the central nervous system. Looking at this cross-section of the human orbit, we can identify a thin, fibrous membrane known as the orbital septum. It separates the superficial tissues of the eyelid from the deeper functional structures of the eye. If a bacterial infection is isolated to the anterior compartment, involving only the eyelids and the surrounding soft tissue, it is defined as preseptal or periorbital cellulitis. If the infection occurs posterior to the septum, infiltrating the deep orbital tissues and fat pads, it is diagnosed as orbital or postseptal cellulitis. This millimeter-thin sheet of fibrous tissue serves as the absolute boundary. Which side of the septum the bacteria occupy determines whether the patient goes home with a prescription or is admitted for emergency medical intervention. Preseptal cellulitis typically begins from the outside in. It follows external insults that break the skin barrier, such as insect bites, superficial trauma, an infected sty, or the spread of conjunctivitis. The primary pathogens driving these superficial infections are Staphylococcus aureus and various Streptococcus species, naturally found on the skin. Behind the septum, the primary threat changes. This 3D model of the facial bones highlights the ethmoid sinus, which sits medially to the eye. An untreated infection here, ethmoid sinusitis, is the most common cause and greatest risk factor for orbital cellulitis. The bone separating the ethmoid sinus from the deep orbit is called the lamina papyracea. It is paper-thin. When pressure and pus build up in the sinus cavity, bacteria can breach this barrier and pour directly into the posterior orbital space. Historically, Haemophilus influenzae type B was a major driver of these severe infections, though its prevalence has decreased thanks to widespread childhood hip vaccination. Less commonly, orbital cellulitis can also result from direct trauma, like penetrating eye injuries and orbital fractures, or hematogenous spread, where bacteria travel through the bloodstream from a distant site. The infection's origin predicts its destination. An external skin break moving inward indicates a preseptal issue, while a deep sinus infection pushing outward suggests a postseptal breach. However, a clinician cannot rely on the appearance of the eyelid to rule out an orbital infection. Swelling, redness, and warmth are superficial signs present in both conditions. The defining characteristic of preseptal cellulitis is that the eye itself remains unaffected. The patient will have normal visual acuity and normal eye movements. To confirm an orbital infection, we look for a mechanical triad of deep postseptal signs. This split-screen comparison shows a normal preseptal eye on the left and the physical disruption caused by deep swelling on the right. The first sign is proptosis. The posterior orbit is a rigid, enclosed bony space. As the deep orbital fat pads swell with inflammation, the expanding volume has nowhere to go but out. It physically pushes the eyeball forward. The second sign is ophthalmoplegia. The deep inflammation directly restricts the extraocular muscles. Trying to move the eye against this inflamed tissue causes pain and limited mobility. The third sign involves visual impairment and diplopia, or double vision. The increased posterior pressure compresses the optic nerve, reducing visual acuity, while the disrupted muscle function prevents the eyes from aligning. Additional indicators of deep orbital involvement include systemic fever and chemosis, which is swelling of the conjunctiva itself. To accurately diagnose the swollen eye, the examining clinician must look past the redness of the eyelid and test the mechanical function of the structures buried deep in the orbit. We tracked a spatial progression of these infections using the Chandler classification. This axial graphic outlines the exact pathway the bacteria take as they move deeper into the skull. Stage 1 is preseptal cellulitis. The infection is confined to the tissues anterior to the orbital septum. Stage 2 marks the breach into orbital cellulitis. Diffuse infection and inflammation spread throughout the posterior orbital tissues, causing the mechanical triad of symptoms. Stage 3 is a subperiosteal abscess. Pus actively collects in a localized pocket between the orbital bone and its lining, the periosteum. Stage 4 is an orbital abscess. The infection coalesces into a discrete, encapsulated pocket of pus directly within the orbital fat and tissues. Stage 5 is cavernous sinus thrombosis. The infection travels through the posterior venous system and enters the intracranial cavity. Reaching stage 5 carries the highest mortality rate in the classification. Once the infection is intracranial, it quickly triggers severe complications, including meningitis, brain abscesses, and subdural empyema. Tracing this anatomical reactions, eye movements, and the degree of proptosis provides the initial suspicion of an orbital breach, but definitive staging requires looking inside the tissue. This contrast-enhanced CT scan of the orbit and paranasal sinuses represents the gold standard for investigation. Clinicians rely on this imaging to achieve 4 specific objectives: confirming the presence of orbital cellulitis, detecting the exact location of any abscess formation, assessing the extent of underlying sinus disease, and identifying any early intracranial spread. In cases where intracranial extension, such as cavernous sinus thrombosis, is suspected based on the clinical exam, an MRI is often utilized to get a clearer view of the soft tissue in the brain. Imaging translates a physical exam into a definitive, actionable roadmap for treatment. This clinical flowchart branches at the orbital septum. For mild preseptal cases with 0 orbital involvement, patients follow the outpatient pathway, receiving oral antibiotics like amoxicillin clavulanic acid or clindamycin. However, these patients require close clinical review to ensure the infection does not progress posteriorly. Any indication of post-septal involvement shifts the management plan. Orbital cellulitis triggers mandatory hospital admission due to the risks of blindness and meningitis. Patients immediately begin an empirical intravenous antibiotic regimen. The chosen agents, such as vancomycin paired with ceftriaxone or piperacillin tazobactam, must cover Staphylococcus aureus, streptococci, and anaerobic bacteria. Medical management shifts to immediate surgical intervention under specific criteria if the patient's vision begins deteriorating or if they fail to improve within 24 to 48 hours of IV antibiotics, or if there is any evidence of intracranial extension. Surgery is designed to physically drain stage 3 subperiosteal or stage 4 orbital abscesses. Often, surgeons will simultaneously perform functional endoscopic sinus surgery to drain the underlying infected ethmoid sinus that caused the breach. When confronted with a pediatric patient presenting with a swollen, red eye, surface-level signs are insufficient. By assessing the mechanical function of the tissues behind the orbital septum, clinicians determine the entirety of the next 24 hours of care, potentially saving the patient's vision and life.